I'm at the SOHO meeting in Houston, and in order to discuss the advances in AML, I think what we need to realize really is that for AML, there were no new drugs available between 1970 and 2017 really to speak of. The drugs that we were using to treat AML were approved in the 1970s. We briefly had some drugs that were approved between 2000 and 2010, but we lost them. And then in 2017, things changed dramatically. In 2017 and 2018, we got 8 new drugs to use in AML, and that allowed us to really change the way we think about treating patients. Before then, all patients really needed to be treated the same way. We had the same drugs to use, and we could decide to use more or less of them, and whether or not to take patients to transplants once we had taken them through the drugs that we had available. But once we had additional drugs available, we were really able to choose to treat patients in a much more personalized fashion. And the reason that happened is because over the last 5 to 10 years, we've developed the ability to really understand AML better and to really categorize the types of diseases we have and to find targets based on the biology of the disease. We've identified mutations that are critical to the AML itself and that have allowed us to actually target the disease. So for example, although we've known for many years that the FLT3 mutation is a very difficult mutation to treat and that patients who have that mutation fare poorly, the only thing we were able to do in the past for patients with the FLT3 mutation is take them to a transplant after we had actually treated the disease with standard therapy. We now have approved drugs that allow us to actually target the FLT3 mutation so that in addition to standard therapy, we can add this targeted drug and more effectively treat the disease. We have a drug that's approved both to be used in combination with standard chemotherapy as initial therapy. We have a second FLT3 targeted drug that allows us to treat patients if they have relapsed disease after they've had standard therapy. Similarly, we have targeted therapy for a mutation called IDH. That again is a targeted therapy that allows us to treat patients that have the IDH mutation rather than treating them with a general therapy that is used to really treat all types of leukemia but doesn't target the type of leukemia that they have. And then probably more exciting is that we have a group of drugs, a BCL2 inhibitor called venetoclax, that can be used to treat a wide variety of patients, but is a much gentler therapy. So in the past, we had to treat all patients with aggressive chemotherapy, and since the average age of leukemia is over age 65, many of our patients were not able to tolerate the aggressive therapy that we have. Now with the use of venetoclax along with hypomethylating agents such as azacitidine, we're able with that combination to treat many patients who would otherwise be unfit for standard therapy and achieve remissions that potentially will be very long-lasting. So we now have a lot of agents to use that we did not have in the past, and we actually have options and challenges and opportunities to even improve even further because we still have a disease that we need to treat. We still have a disease that has a high risk of recurrence and relapse, but we now have a lot more tools in our tool chest than we did in the past.